We're good? Okay. All right, I believe we are live. Good afternoon. Today is October 16th. This is United Medical ACO live sessions. This is our session number 12. We have different topics and we have our guests today. So we're gonna go through those together. First, I'm gonna start sharing my screen so then everyone can see what I'm looking at. Very quick background, since this is our 12th session and then we do others outside of this now, most of the people, they know who we are, so I'm not going to spend too much time, but we do provide services in electronic medical records, practice managements in the outpatient setting, and we are one of the 4 ACOs, accountable care organizations in Delaware, provide services for almost 100,000 primary care patients and close to 250,000 on the specialties in the outpatient setting. And we do have a surgery center, American Surgery Center, as part of our program, other than our specialties. So that's who we are from the United Medical side. I do have a state official with me today, so I'm going to actually just mention a couple things on the triple aim, where the healthcare actually is designed around the triple aim, and from United Medical ACO, we are taking this to a next level, and we are adding the physician and physician practices, our providers, so making this more like a quadruple aim. So that's kind of like our signature slogan in a way, if you will. So that's what we are trying to focus on. Now, today I have a special guest, Senator Bryan Townsend, who's with us. You are right now seeing him on the screen, so I'm going to ask him to introduce himself, and then we have some questions for him as he's heavily interested in the healthcare side of the business. So, Bryan, if you can please introduce yourself.
Certainly. Thank you so much for having me today. I'm Bryan Townsend, state senator for the South Newark area, just south of the city of Newark, down to Route 40 and a little bit of Bear. I've been a state senator since 2012 election. I'm currently the chair of the Senate Health Committee and the Senate Majority Whip. My day job is I'm an attorney. I'm a Delaware corporate litigator. And just one reason, just to explain my interest in healthcare, is actually I never meant to be a lawyer or a senator. I had wanted to go to a medical school actually and become a pediatric cardiologist. So my undergraduate at the University of Delaware was broad-based, designed to have me be a well-rounded doctor. I had a chance to go overseas for graduate school at the University of Cambridge and studied Chinese in England and in China. And while I was there, I decided to take a different path than medical school. But when I ended up going to law school and then being back home in Delaware and deciding ultimately to run for the Senate, I have very much had an interest in healthcare, and then became chair of the Senate Health Committee in 2017. And since then have focused a lot on access issues, as well as certain kinds of healthcare reform and restructuring. Obviously, on an audience like this, you all know as well as anybody, the complexities of healthcare and the improvements that we have got to try to see. Very much for me, it's focused on patient care, physician and medical provider, autonomy to be able to do the best patient care, and to try and focus a lot on the gains that we all can have with more investment in primary care, which in Delaware is underutilized compared to some other jurisdictions. So it's a huge part of the state budget, huge part of society, obviously healthcare at the national level as well, just such a fortunately controversial issue, but I think very much if we can focus in on health outcomes, health access, there's a lot of gains we can have if we're willing to really focus on those aspects of it. So I really appreciate the chance to join you all today and look forward to chatting.
Thank you. Thank you. I was just talking to you earlier. Well, we didn't share our questions with you. We didn't rehearse this, so it's more like two friends talking. But I just realized that also we haven't met before, which is kind of interesting because I do have a lot of interest in politics, and we work with so many different officials, and it just didn't work out. But I remember I actually follow your activities on healthcare, and your help with the primary care bill. And also, every time we have issues, I know from our United Medical leadership side, Anthony Anugu, who's in touch with your office on a regular basis. And we do really appreciate when you and your office is able to hear our concerns, and we are able to voice them out and then get good responses from you. We do actually appreciate that, and I want you to know that. Now, Bryan, what we do in this meeting, this is something that I do with our providers on a weekly basis. Mm-hmm. And after we did so many of them, it turned out that, okay, well, we can actually reach out to the patients, our existing patients, perhaps our new patients, but also general public, to actually educate them and keep them up to date with what's happening from our side. And I do share the US level numbers in terms of total cases. One of the things that I do, just to make it easier for everyone to see, I have the April and May numbers so that they can easily compare this. So right now we are getting to almost now over 8 million. So 8,224,000 is our total number of cases. Total number of deaths is over 222,000. And when we look at like where we were in April, it kind of just shows us how big the discrepancy is, how big the gap is, and it makes it even more important for us to pay more attention. And from here, I take our patients to the state level. Delaware is our home state, although I was not born in Delaware. This is my home state in the last 22 years. So when I look at the numbers, one of my concerns that I would like to share with you is a number of tests in 1 million is one of the struggles that I believe we are having. And because I'm sharing these numbers every day with our providers, I always compare with the US average and the states similar to us. And I'm sure you are probably going through the Rhode Island comparison, not only in just healthcare, but for anything else. So we're always compared to Rhode Island. So in the beginning, we were around like US average in terms of tests in 1 million, which is it's about 370,000. And then slowly we were actually dropping from that. And then we are now down to 327. We are actually like in the middle US, like 9 states, I believe, is over us under that average. Now, in your opinion, how are we dealing with the COVID management at the state level?
Well, my opinion overall is we're doing pretty well. I certainly check on a daily or near daily basis around the country now and to see what states are spiking. And Delaware seems to not be spiking. Obviously, it's not spiking the way that some other parts of the country are. I think globally, or just from like a 30,000 foot view, we've done quite well in the sense that we've looked at data, believed in data, tried to make our decisions based on data, haven't sort of tried to cave to some of the political winds or community sentiment, because people are frustrated, and I get it. The businesses are frustrated. Certainly the medical community was frustrated by the shifting of medical care, but I think also understood what their sisters and brothers in the medical profession were going through in trying to treat a pandemic. Parents are frustrated with regard to schooling and kids not in school and seeing kids not be able to learn as well. I mean, so everybody is frustrated. But I think Delaware, under Governor Carney in particular, has hewed so closely to data and public health experts and making some tough decisions. So in that sense, overall, I think we're doing well. I think we're seeing that we are not spiking in the way that many other states are. We certainly have seen some upticks in the past few weeks in the Newark area, for example, at the University of Delaware. We had seen some major events throughout the state. We saw some tensions in Sussex County a few months ago, just generally not even connected to specific events necessarily. So we can point to those things and say, well, we need to do better. But I think when you look at the global numbers in terms of rates and cases, we don't seem to be spiking the way other places are. We certainly have not seen it go down as much as we had hoped it would. And so in some ways, I wonder if Delaware ends up being an example right now of sort of a middle ground. I don't want to say sustainable, because it's clearly this can turn so quickly, right? You can have a couple of bad weeks, and given the rate of transmission, it could really result in serious problems with regard to spikes of cases and spikes of hospitalizations. To my knowledge, the actual clinical aspect of it has gotten better in terms of treatment. And I should say, by the way, the long-term care centers are very much what drove part of the problem earlier on. We've seen a couple of those more recently as well. And that is another reason why some of our numbers looked worse earlier on, is that very unfortunately, COVID got into some of our long-term care setting centers, including in my district. My district has Little Sisters of the Poor, which was the first long-term care center in Delaware where there was a COVID outbreak, and I lost constituents. I lost friends who lived there. Very, very sad. And so I think overall, though, we are doing, we're kind of doing well. We sort of reached this sort of steady state in some ways. And I guess my explanation for why we haven't seen it go down as much as we would have liked it to have is because the only way you're going to get it down that far is sort of like just utter and complete shutdown of everything in a way that itself can be very difficult to sustain.
Sure. Well, thank you for that. Now, Bryan, the other thing that you were just mentioning, and then you actually kind of start talking about the digital health part of it, and this event and several other live sessions that we do, our goal is to put more support out there for our patients. So telemedicine was not used at all prior to March. With the pandemic, we actually, from our accountable care organization, our board has 11 members. I'm the chairman, but I have 10 providers, 5 on primary care and 5 on specialists. And our immediate reaction was how quickly we can actually get telemedicine up and running and adopt and keep the patients home. And we did phenomenal from that point, because in 3-4 weeks time period, we were back to our prior to pandemic numbers in terms of total appointments. And then 60% and more was on telemedicine. Some primary care, they were strictly telemedicine for a while. Now, we do these events in a way that there are some clinical sessions that we do. And if the patients are home and if they feel they need more information, more knowledge, then we are trying to provide that with our physicians, who are usually my guests in this session. And 2 weeks ago, actually, we had Dr. Jan Lee from DIN, the CEO of DIN. She was with us. We talk about the digital health. Now, I would like to know, and because you do have the bill, you are sponsoring the bill, the HB 348, right, on the telemedicine. I didn't read the entire thing. I'm not going to lie to you, but one thing that I'm interested in, are you supporting to make the telemedicine changes permanent, so that we can actually, after the pandemic, we can still keep doing the telemedicine, especially for those elderly who are always at risk with the flu seasons and others. So what's your position on that?
Yes, I think my position, represents perhaps literally unanimity throughout the General Assembly on this issue. Yes, we intend to make telemedicine expansion permanent. I can't say it's going to be exactly what it looks like in the bill that we passed this year, mainly because we certainly assume that the medical profession is going to learn new things in the coming months about additional changes that might be helpful. But fundamentally, we put a sunset clause in there. It's what you're referencing, right? Is the idea this expires next year. And the reason we did that simply was to try and acknowledge that we were making these decisions in the middle of a pandemic when we ourselves were doing virtual session. Like, we weren't in person with each other as legislators. We didn't have the committee hearings to hear additional feedback. And so we put in a sunset clause to force us to come back next year and make it permanent, and with the hope that by next year, we'll be back to more of a normal session. We can have committee testimony. We want to have fidelity to the open, transparent legislative process. But we did hear right away from people that, wait a minute, what does this mean? You're putting a sunset in there? Like, what happens next year? We're investing in technology upgrades as an ACO or as a stakeholder. What assurances do we have that this is going to be around next year? And our point was, no, it will be around next year, largely the same, if not identical. But we just wanted to try and show that we were not indifferent to the fact that we were legislating virtually. So I'm all ears to whatever changes you think we need to make to enhance the system even further.
So when I was talking to Dr. Lee, I want to share that with you. Actually, she used the term silver lining from this crisis that we are going through. So because now telemedicine is heavily utilized response to the COVID, we also are going through the flu season. And in the flu season, the projected numbers anywhere from 40,000 to 80,000 people die every year on the projection. So, and then most of those are elderlies. And then my point was, well, we'll keep more people home, so maybe we'll lose less people on the other side of this. So, and then if the telemedicine is there to stay, then we would be able to manage. Because the other thing that we are doing, when we need to see the patients, we are not actually closed. Obviously, we are seeing patients in our offices, but the main issue with the social distancing, for us to be able to have less number of people physically in the office while we are still doing telemedicine in between, that's just kind of the almost like the model for us for the future. So I do believe that it needs to be there long term, but also certain standards needs to be brought. We need to bring certain standards so then providers and the patients are not taking this lightly in any way, because we don't want to compromise the quality. And that's part of my education for our providers, that like technical support that they need, 2 screens. Like right now I'm on 2 screens with this, but then when I'm with if our providers, when they are seeing patients, we want to make sure that they have technology, they have connection, and also what patients can do on their side. Sometimes, they call us from while they're shopping or while they're driving. So
I hadn't heard that. That's something else.
So we don't want to actually compromise the quality in any way. And I don't know if you were able to see my, I do write once a month usually, and on this digital age, the communication issues and how we are adapting to the changes and what we are expecting, like do's and don'ts of business meetings and telemedicine. Like I was just going side by side with the business and the healthcare. So it was, it got a lot of good responses and feedback. And just to make the expectation kind of set so that everyone takes this seriously, because I'm concerned if we don't do it right, then the outcome is going to be bad. So if we can work on quality and the long term of that trust needs to be there from the physician side to the system, so then they can actually make permanent changes on their side as well. Now, Bryan, one of the other things, unfortunately, this time it did probably come up a little bit more, like we became more and more aware of some of the other issues and the racial disparities of the disease that we are going through. It impacted people in a different way. So when I had one of our sessions with one of our primary carers, Dr. Barnett Smith from United Medical Clinic, she gave us this education session on her side of what issues she's going through as a provider and what she sees and how we can actually help. And personally, it does bother me a lot when we still have to talk about these types of issues. Like these issues are still an issue, like that bothers me. So I'm hoping that we can learn and adapt certain things very quickly and make certain adjustments. Now, in my practices, I'll just tell you, I wasn't going to talk about this one, but I'll just tell you something interesting. With our Google account yesterday, our IT guy made a little update, and somehow my cell phone number at the account level went into one of our physicians' profile. So when you Google him, the contact number is my cell phone number. And the patient calls, and then clearly it's a patient, but she doesn't know who she's calling for, knows the doctor's name. This was one of our doctors, colorectal surgeon, Dr. Sachin Vaid. And then I said, look, I'm the CEO of the company, but you're calling my cell phone. Then once she said, well, I got your name from Google. First, I wasn't sure if she was real. I'm like, then I checked it. I'm like, okay, I see my cell phone number. So then I said, look, how can we help? So I didn't ask her what her race was. I didn't ask her what her background was. She was someone whose husband is actually going through cancer, colorectal cancer, and they missed their appointment in the morning. And then she was trying to get in, and it's difficult to get into the schedule, especially these days. So, every time there's something happens, I always look for the good reasons. So it was maybe the blessing that my number ended up on Google. So because I got her in right on that same day, and then later on I checked, and then she was actually like crying on the phone. She was so happy. But we don't actually treat the patients in any way. Like, we don't see them as like, you are black, you are white, you are yellow, you are whatever the background it is. So that's why sometimes I feel like this is not happening. But then when we go out there, we see the issues. So what can we do from your side, from your position? What can we do to improve these disparities?
And I think the question seems like it's focused, on the broader disparities, not just simply the immediate disparities as they're manifesting itself through COVID, which, there are some efforts to tackle that by making sure that testing was more widely available in some of the communities. But yeah, I just think that the problem, the structural inequalities throughout our system is they all add up to have a tremendously negative impact. And I think that it's important for us to do a whole lot more investment in the community to try and address this. I mean, everything from rates of diabetes is one example. Everything from access or trust in the healthcare system, ease of access in certain communities, school-based wellness centers for children and families for whom school is sort of the only kind of unifying force in the community. I wish there was like one simple answer I can give you, but the problem is it's so multifaceted, it's so broad and deep that it's got to be a whole lot of different things all at once. I know that in particular, maternal and child health has become a bit of a focus, an increasing focus. Everything from the role of doulas in the health process, the delivery process, and the prenatal process. To postpartum, coverage under Medicaid, for example. I mean, a lot of things what you're talking about, the disparities, ends up being Medicaid, although not only. And so I think we just have to have that plus a broader conversation of primary care of how do we just make sure to channel investment to try and keep people well on the front end. If you don't keep people well on the front end, and you know this as well as anybody, there's just a tremendous cost on the back end trying to then address their health conditions. And that existed all along. But to your point, to the framing of the question, it was so tragically revealed by COVID in the disparate rates that COVID affected people based on health status. So we've got to find a way, however the government or broader institutions touch people, we've got to find a way to make sure that a focus on wellness and primary care is paramount. Otherwise, it's just so hard to tackle these disparities on the back end.
Absolutely. And one of the things that Dr. Barnett-Smith was also telling us, she says, well, we know that this is an uncomfortable discussion and topic, but let's talk about it. Let's be uncomfortable, but let's just talk about it. So then more people know, more people are aware. And we are here to do more. We just, our goal is to help, not just from the patient side, but the society that we live in. If my office, our company name is United Medical, but sometimes we kind of joke around, it's like United Nations. So we have so many different backgrounds, so many different religions, so many different races. So, but we see the person, we don't see anything else. So, and that's something that needs to be at a broader level. And we are here to do more. And if you have any projects that you would like to participate, we would be more than happy to do that. One of the other things that I was going to ask you now, this is an example of how we are trying to make these things a little bit more accessible for our patients. Like when we do these events, any clinical learning points, we are actually keeping them in a playlist specific, so then they can go in, like we have one on our bariatric program. This is on our weekly program here. So what things that we are able to do, our social worker, our dietitians, they are doing different wellness webinars. In fact, like we had one yesterday with Dr. Dhruv Patel. He's a nephrologist. Our center is an accredited center for the diabetes. So Amy Wilkerson is the registered dietitian. She's leading that program. And they did one event last night. Now, On the bariatric side this week, this was our volume 7 with Dr. Irgao, Dr. Isaias Irgao. He's also vice chair of United Medical ACO. We are kind of breaking the obesity is in 7 different sessions, smaller sessions, and just focusing on different parts of the obesity. That's what we are kind of trying to help. Like next week, we have one with Dr. Ibrahim from the same group. And like we ask the state Delaware Health and Social Services medical director, Dr. Rick Hong, and he's going to be available for this session. Now, my final question, or maybe just to share this with you, because we haven't talked, we haven't met before. So one of the approach that I see in crisis, especially in healthcare, immediately how we are focusing on what hospitals can do. And we understand that when the situation is severe and the patient needs to be in the hospital setting, the hospitals are the key. But sometimes I feel we are kind of alone from the outpatient practices standpoint, where we actually do a lot more work and we can be utilized a lot better because we actually keep the patients away from the hospitals. So when this pandemic started, by keeping the transitioning to telemedicine immediately and then start testing them in our own offices, it was safer. So like when you get the test done in the hospital versus when you are in the private office, the outpatient office, your exposure is less. Just because there are more people in one place versus not, but also it's less expensive in the outpatient setting, more than the cost, but just for how much actually we do. Since March 17th, we have seen 93,000 Delawareans in our network with 240,000 appointments. And these are not in the hospital, these are in private, by the private practices. When we have that kind of number, sometimes I feel like we are not approaching it correctly, so that we are just going to the crisis center. Well, let's see what hospitals can do. Well, we have outpatient practices can do a lot more and better, and if they can be supported more, we can actually even improve what we are doing. Do you feel that there's some disconnect on that side, or what do you think on my concern maybe?
Yes, 100%. I would like to leave it at that, only because I'm not known for being concise, but obviously it's a huge topic and I'll say a little bit more. I think that health is, health is not like so easily a sort of free market economics or a perfect, economic model. The assumptions that are baked into, economics don't apply to health. I mean, people don't value their own health appropriately. They'll often wait till a crisis happens. They'll often maybe eat not very well until until a problem actually becomes more severe. If you have a broken bone, like you're going to the ER or something, right? I mean, or put more differently and more personally for me, I've got a 3-year-old son and a 5-month-old son. If they have a health issue, I'm not picking up the phone and shopping around for different provider costs, right? Or charges. I'm trying to get my sons taken care of. And so I think that it comes down to more policymakers and leaders like yourself and your group to figure out how to point the system in a more productive direction, because it's just such an imperfect, from an economics perspective, an imperfect system, a lot of flaws in the system that we've got to try to steer and correct for. And right now, yes, hospitals can play a great role on things, but they can't or haven't been sort of the lower cost leader to actually keep people healthy. And in some ways, that's okay, because that's not their role per se. And obviously there's a lot of complexity, because then hospital networks might buy up, primary care provider practices. And then now the question is, okay, what's the role here? What are the incentives here baked into the system? I think groups like yours are part of from kind of bottom up, ground up building to try and correct these flaws. So it's a complicated issue. It's fraught with tough decision making and very difficult pressures. But I think we have to, at least my perspective is, we have to be honest in having the conversations about it from a public policy perspective. If we truly want to keep people well at a lower cost, with less pain and suffering for them and their families, just better health, then we have to make sure our system is oriented in the right ways. And too often across the country, and even in Delaware, we haven't been as good about it as a policymaking, framework as we need to be. And so I'm all ears. So whenever you and your group thinks, hey, let's try this, or let's do that, or have you seen this data, or can we try this pilot program? I think we've got to be dynamic, because the health system just is not working in the US the way that other countries have shown it can.
Yeah, well, I do appreciate that. Bryan, this was very enjoyable. And sometimes when we do these events, we are always on the healthcare, and I wasn't 100% sure when we have a politician in this, if it was going to be a good, sincere dialogue. And I think I enjoyed it a lot. And I do see your interest in the society and healthcare, and I believe you are there for us and for Delawareans, and I do appreciate that. So thank you for joining us, and hopefully maybe we'll bring you back in the next couple of months after the elections, and let us know if there's anything we can do for you as well with your programs and committees that you are running. But we are going to be back next week. And try to keep the event under 30 minutes. So, and I know you are very busy as well, and we do appreciate your time. Thank you so much.
Thank you so much for having me. Thank you.
Bye-bye.